welcome all. So I'm Margaret. I'm from Hong Kong, China. So today, welcome to the CCOT webinar on the salvage mangled extremity, the emergency management of protocol. So before we start, we'll first invite speakers. Who is from Cambridge, is an orthopedic surgeon from Cambridge, and he is one of the key person who started off with this CCOT pioneer, and he is currently the chair of the Education Academy of CCOT. So without further ado, I would like speakers to start.
Thank you very much, Margaret, and a very, very good morning, good afternoon, and good evening, ladies and gentlemen. As Margaret said, I'm Vikas Kanduja. I'm a consultant orthopedic surgeon in Cambridge, UK, and I'm an academy in CCOT. And it's indeed a pleasure to extend a very warm welcome from CCOT Pioneer to all of you logging in from various corners of the world. Now, we're all very mangled extremity can lead to a high rate of mortality if not managed appropriately, and potentially a permanent disability in the patient as well. Now, today's webinar focuses on salvaging a mangled extremity and the emergency protocol for management of the same. Our moderators today are Professor Qing Tang from China, who's the chair of the Microsurgery Committee in CCOT, Professor Margaret Fock from Hong Kong, who's the chair of the Hand Committee in CCOT, and Professor Egypt. We would like to has gathered from all around the world and before I hand over to our moderators, we at CCOT Pioneer strive to make every session as interactive as possible. So for the global audience following this live webcast, please post in your comments and questions in the discussion box as we progress through this webinar this evening. Our moderators and panelists will address these questions and go along as we go along and choose some to discuss live at the end of the webinar. And for those of you who are not able to join us, we have the option of the on-demand viewing on our educational platform, Panopto. So once again, a very warm welcome to all of you watching and hope you enjoy the webinar. Without much further ado, I hand over to Margaret, Professor Qing Tang, and Dr. Ahmed Adulski for taking us through the proceedings.
Okay. Thank you, Vikas. Professor Zhu, do you want to?
Hello. Have you finished, Dr. Falk? Can you hear me?
Yes.
Okay. Welcome everyone. This is a very nice webinar. Very important. It's talking about the salvaging of mangled extremity, the emergency management protocol. And thank you, Dr. Zhu, for inviting me to this very valuable, fruitful webinar. Maybe we can start just right now, and I invite Dr. Zhu to start. He's going to talk about the comprehensive management for severe extremity injury. I invite Dr. Zhu to start the webinar.
Okay, thank you, Dr. And before my lecture, actually, I would like to invite Alice to speak about this webinar, because he is the chair of the European Federation of Society of Microsurgery. So would Dr. Alice, would you just speak?
Thank you very much, Qing Tang. So I'm very happy to co-chair with you, and thank you for this invitation. This, I think, very important mangled extremity. It's a very important issue in the hands of a microsurgeon, or also of an orthopedic surgeon sometimes. So we have to talk about a lot of main topics, and especially about orthoplastic approach and microsurgical approach in this kind of lesions. From the part of European Federation of Microsurgery, as president of the federation in this moment, I want to welcome all of you, and I'm sure that this will be for sure a very nice session today. Thank you very much again.
So thank you, Alice. So maybe we should have Professor Zhu to give us his
our principle for comprehensive management for the severe extremity injury. The so-called is a 1-2-4-A rules. I come from Department of Microsurgery and Orthopedic Trauma and Hand Surgeon in the first affiliated hospital of Sun Yat-sen University in Guangzhou, China. So the mangled extremity most of the time is life-threatening and sometimes limb-threatening and sometimes is life-threatening injury. So to treat those mangled extremity is need to treat it very in time. That means it's time sensitive. We have to shorten the time to treat these patients. However, because the injury is so complex, so it takes time to repair and reconstruct. And also, it needs a multidisciplinary team to be involved to treat this patient. It might include orthopedics team, vascular surgeon team, and plastic surgeon team. But even this a big team to work together, there's still high rates in complications and amputation and disability, just like this case where we saw. So it's really challenge to salvage such a mangled extremity. So here is our hospital in our department to use the roles for comprehensive of management. We take the vascularization is the first priority. So we need to evaluate and restore the blood supply to the extremity is our first task. And those patients, we just staged treatment for those patients, include the emergency stage, the little resuscitation and damage control for the patient, for the life, and also for the limb. Only if this definitive repair is feasible, and also this life, the vital sign is stable, and so the limb can be salvaged, then we can follow the reconstruction procedures. So for the early management of this kind of patient, we take the following key points. Include, at first is assess the patient and also classify the vascular injury as well as the fractures and the soft tissue injury. Of course, the debridement and the wound coverage is the key for prevent infection and non-ruling. Then the cause of the early management is restored the circulation to the injured limbs, and fracture fixation is stabilize the limb. So we will address these 4 issues during the early management. Including the early stage or the late stage, usually you will need to use the following 8 techniques. Include you will need to shorten the ischemia time. You put a shunt if there's an artery injury. You put a intravascular shunt in the injured vessel stem. If there's a soft tissue defect, sometimes we need to use a flow flap to repair, to restore the vessel as well as the soft tissue coverage. If this soft tissue is extensive, the injury, and probably we cannot achieve the radical debridement, we may use a very specific method includes such as the cross-limb vessel transfer to restore the distal circulation. And the other techniques such as external and internal fixation and negative pressure wound therapies is common use in the treatment of those cases. And for the late stage, if there's a bone loss or some defect, we may need a bone graft or bone transportation or lengthening to restore the skeletal structures. And if there's a soft tissue defect, we'll initiate a compound tissue transfer such as the skin flap or muscular skin flap. In the late stage, if there's a loss of function due to the such as the compartment or the loss of massive muscle, it may need to use the functional free muscle transfer to restore the function. So here we propose the classification system for artery injury. Is based on the soft tissue coverage. We divide in the type 1, type 2, and type 3. If there's a healthy soft tissue, we call it a type 1. If there's a low health soft tissue cover the injury, we say it's a type 2. And the type 3 is extensive the lesion, or the boundary of the injury part is unrecognizable. And also, we classify the vessels injury based on the condition of the vessel and divide the type A, B, C. Such as this, the soft tissue coverage is very good because we can treat it as a normal, a regular method. However, for this kind of injury, after debridement, the vessels cannot cover with healthy tissues. And for type 3, the extensive lesion, and because of the high energy injury or the secondary infection, so we are unable to debridement thoroughly and primarily repair the vessels. So repair for the type 1, because there's just a regular method, no matter it's a direct repair or graft or the use the living graft or the vascular graft is okay for this kind of injury. However, for the type 2, because there's low healthy soft tissue coverage, if only use the vein graft as a regular, it may fail, just like this case showed. So at this time, we need to repair the vessels and the soft tissue coverage. Most of the time, we use the flow-through flap to coverage, like this case. If the ischemia time is expected, ischemia time is longer than 6 hours, we'll put a shunt to shortening the ischemia time first, and then harvest free flap to restore the blood flow as well as the soft tissue coverage. If for the type 3, that means cannot repair primarily. So we just spend this part and use the distal cross-limb artery to restore the distal blood supply. And after heal of the injury sites, we harvest and other flaps, just like the type 2 to restore. So like this case, to restore the blood vessels. The Gostino-Anderson classification for open fracture is very familiar. However, if this injury, the range is larger than the one part, we just classify is the type 3D. That means the extensive soft tissue defect plus the vessel injuries. This is a case we may salvage the patient use the vessel repair and soft tissue reconstruction. first of all, for this case, and for this kind of injury, we classify as a type 4. That means the extensive injury of the limb is salvageable. For the type 3D, we said this kind of injury, we harvest ALT, just like the flow throat flaps to restore the circulation and cover the soft tissue defect and use an external fixation. And 3 months later, we transferred to the internal fixation. And the final stage, use the functional free muscle transfer to restore the function of the upper extremities. That's our way to treat the type 3D open fracture. So for the mangled extremity, we just want to emphasize again those 1, 2, 4, 8 aspects of our treatment principle. That means that we have to revascularization of the limb first, and divide in the treatment protocol in 2 stages. And during the early stage, in the early stage management, we will assess and classify the injury and include the wound coverage and the circulations. About the technique you use include in the early stage from the temporary intravascularization, flow flap, and cross-limb muscle transfer in the special cases, and also the external fixator. And in the late stage, we did the bone graft and transportation and other soft tissue transfer and the flap, include the functional free muscle transfer to restore the function of the mangled extremities. And I would like to thank our team from our department and work hard, and thank you for all of your attention. Thank you.
So thank you, Professor Chu. So next we'll have my co-moderator, Professor Ahmed Adolski, who is the Vice Chair of the Microsurgery Committee of CCOT, and he's also the Vice Chief of the SOHUT Hand and Microsurgery Unit, and is the Professor of Orthopedic Surgery of the Orthopedic Surgery Department of SOHUT University, Egypt. So he is going to talk about the mangled extremities, replants or amputate, a difficult decision.
Okay, thank you very much, Margaret. I will start my presentation. Okay, hello everyone. I'm going to talk about the mangled extremity replant or amputate, a difficult decision. We'll talk in short about the history of the plantation. William Powerful performed the first fingertip reattachment. It is just reattachment in 1814, and Hunter in 1815 did perform the first thumb reattachment. Still, he just do a reattachment without vascular, microvascular vascular attachment repair, I think. They performed the canine limb replantation experimentation in 1880s. And for that work, Carroll won the Nobel Prize for his work in 1912. Professor Malt in 1962 performed the first successful replantation of an entire limb. Dr. Kamatsu Tamai from Japan in 1968, they performed the first microscopic digit replantation. What the treatment option do we have in case of the severely mangled extremity? The question is if the limb is salvageable, and if salvageable, will we have a good functional replantation? This is the question we should ask ourselves before deciding whether to amputate or replant. What are the scenarios that we have? Either we do an immediate amputation, or we may try attempt to salvage with early amputation sometimes if it failed, or we have a successful salvage or unsuccessful later on. So many scores that evaluation of the mangled extremity to evaluate salvageable or not, including score and also the Hanover fracture scale 87. However, all these scores do not correlate well with the final limb function. And this is also a sleep study evaluation of all these scores demonstrating that these scores does not correlate with the limb functional outcome later on. And also it cannot be used solely for decision whether to replant or amputate. Actually, the decision not to replant is much more compelling in the lower limb because the function of the lower limb can be replaced by prosthesis easily. Also, the injury is usually more severe and the patient usually have a polytrauma. Also, the unpredictable recovery of the repaired nerves in the lower limb. The severe general complications or local complications such as necrosis, infection, and non-union, the need for secondary procedures, and the economic cost for the patient and the community. What are the indications of amputation? Actually, there are absolute indications and relative ones. The absolute one is a severely crushed bone and soft tissue that is beyond repair, that is severely crushed limb that cannot be repaired. Also, we have a crush injury with a worm skin or non-repairable vascular injury. These are the absolute indications that we cannot do replant bone and soft tissue reconstruction that is not personal, social, or psychologically compatible with the patient. The indications of replantation are the anatomically intact sciatic nerve or tibial nerve. We can reconstruct the vascular injury. We have a proximal injury with a worm ischemia that is less than 6 hours, moderate and bone and soft tissue injury. We have a good functioning ankle, foot, and knee, a young age, and a bilateral amputations. On all these situations, we have to try replantation. The goal of our replantation is that we have a functional, sensate, pain-free, stable, and aesthetically pleasing limb. We do not only need to have a viable limb. The limb must achieve most of these goals. Not all of them, but most of them. This is our goal, to achieve all of these ones. McKinsey et al. Studied the factors that affected the decision to amputate or reconstruct 527 patients with gastrotype 3B and 3C. Studied the functional outcome of severe lower limb injuries after replantation. He found that the overall secondary amputations with about 20% need a secondary amputation, and the salvage rate is 75%. 80% of his patients require secondary procedures. The salvageable limb with a mangled extremity score less than 9 exhibited a significant difference in achieving adequate function. The mangled extremity score. According to studies that if we add a pre-function transfer to the replantation at the same time, whether this will expand the indications for pre or failed replantation. As already Dr. Zhu demonstrated that sometimes he add a pre-tissue transfer in order to overcome to provide good soft tissue coverage and to enhance the replantation. And he concluded that the indication for lower limb salvage may be enhanced and successful results can be obtained in one stage with a low complication rate and shorter hospital stay if he used a pre-tissue transfer along with replantation. And they found that about 90% of patients has a good sensory recovery, more than SE2 plus. Masada Isa reported a 17 years follow-up of replantation of a child, completely amputated leg in a child, 4 years old. And he found that the child maintained a good cosmosis and function with a very minimal small size of the foot and shortening. So limb replantation should be all in the bilateral lower limb amputation and the multiple amputation. Expect prolonged hospital stay, delays, mobilization, secondary procedures, amputation with severe soft tissue injury or other systemic injuries. Thank you very much for your attention.
Okay, thank you, Ahmed. So before we have the next one to prepare our talk, which is Professor Jacques Hackelbord from USA, who's going to talk to us about planning in reconstructive severely traumatized upper extremity. What does the patient need, and which test do we order? If anybody have any questions, you can put it up on the web as well. And now I would like to introduce. In the meantime, I would like to introduce Professor Jacques, who is the assistant professor of the Department of Orthopedic Surgery, and Humboldt-Weiss Department of Plastic Surgery, New York University School of Medicine. And he's also the co-chief of the hand surgery service of the Bellevue Hospital Center. So without further ado, let's have Professor Hackelbord to talk about the planning of reconstructive of severely traumatized upper extremities.
Hello, everyone. Thank you very much for including me. Professor Jingtang, thank you for inviting me to join this esteemed group. I apologize if I seem a little sleepy because it's pretty early here. And we're also currently on holiday. And yesterday I realized any nice clothes. So I apologize for being dressed so casually. It's not normally how I dress for these webinars. But so this talk is about planning, not doing. The speakers and their talks are incredibly interesting. And but this talk is different, though. This talk is, I won't be showing you tips and techniques or how I approach the specific treatment, but more about the planning stage, which doesn't seem like a very interesting stage, but it is incredibly important, especially for these patients that come in with more chronic problems. The planning part is oftentimes more important than the actual doing. So you have this patient that comes to you. This patient obviously has had significant deficits and trauma from previous injury. This patient had a previous compartment syndrome. And he has minimal function of his hand and, of course, a huge deficit in muscle bulk of his forearm. And many times when you're first starting and when this is new to you, it is a little overwhelming of where do you start with this patient? How do you assess what needs to be done, what is lacking, and what the appropriate next steps are? There are, of course, many things that we can do to this patient, but the question is, what is the right thing to do and in what sequence? So step one with these patients is you have to determine the patient's need. You have to determine what does the patient need. Now, lacking something is not the same as needing something. These patients lack a lot, but you cannot reconstruct everything. You cannot reconstruct everything that they lack. So you must assess what they need. How do you determine that? Well, the first things that you ask is speaking with the patient and identifying to the patient the specific functions that are lost. Many times these patients come in and will tell you so many things that they cannot do. But what is important for you is to define that into very specific tasks. So you ask them in the course of the day, what are the specific things that they cannot do? And then you ask the patient to list these things in the priorities. What is the thing that is the most important to them? What is the second most? And it's very important for me when I talk to my patients to list it from 1, 2, 3, and so forth. Because if they list to you 10 things that they are lacking, if 10 specific functions that they cannot do, it is important for you to have them label it as a priority and a hierarchy. And then also times it is important for you use your judgment and to categorize those things, because many times specific functions that they've lost can be categorized into groups. For instance, this patient has had he has a seizure disorder, and unfortunately had a seizure and sustained laceration, a significant laceration to the volar forearm that was treated not very, very well, and he has significant problems. So he is burning himself at the fingertips. He can't grasp objects with his fingers, and this is very debilitating to him. Can't use the hand, and then this area is very painful. These are the three things that he described. The next step is to translate this patient need into the specific lost anatomy. So lost patient functions you translate into what anatomy that is lost or is dysfunctional explains these deficiencies in this disabilities in these patients. So you must translate their need into anatomy. So this patient here has a significant wrist contracture. This is a 5-year-old boy who had infantile compartment syndrome that has had debridements and other contracture releases. So this boy has a significant wrist contracture. He has an unstable thumb, and he has no functional muscle in his forearm. He has needs, but now we take those needs and we define them into the anatomy that is lost, or the deficient anatomy, as well as he's complaining of significant deformity. His mother specifically, she really dislikes the way that this looks, and he has no subcutaneous fat over this area, and that is not something that we think is that significant, but to the patient it is very significant. The next step is you have their needs, you have the lost functional anatomy. The next step is for us to determine what is feasible. These patients have so many deficits and so many things that are wrong. We cannot reconstruct everything. So before we can decide what we can reconstruct, it is important to know the lost functional anatomy. And then we look at what is there and what is not there. What is the anatomy that is functioning? What is the anatomy that is there but is dysfunctioning? And can we improve that anatomy? For instance, with joint stiffness, is the joint salvageable? Or does the joint need to be replaced? Or does the joint need to be fused? To know what we have, this is the step that we obtain the studies. The appropriate studies help us to determine the anatomy that they have and the anatomy that they need. The studies are all familiar studies. These are no special studies whatsoever. You take this patient who's had a previous hand replant, who has essentially no function of the hand. She has a painful prominence over this area. X-ray is all we need. She dislikes the position of the wrist. So we need to see what is the condition of the radial carpal joint. Is it fused? Is it not fused? And what is the position of that wrist on the X-ray? X-ray is all that we need. She also has a very stiff joint, very stiff, a significant stiffness with passive range of motion. Once again, just the X-rays are necessary to look at the condition of the joint. Are the joints fused? Are the joints congruent? Do the joints have significant arthrosis? Her active range of motion is less than her passive range of motion. For this, ultrasound is necessary to determine are the tendons from the previous replant, are they intact? Are they not intact? If they are intact, are they significantly scarred? And the patient has significant cold intolerance. All that we need for this is a CT angiogram to determine, does she have intact radial and ulnar arteries in the forearm and in the hand, or is only one or none of them intact? So as you can see with this patient with a relatively complex problem with significant deficiencies, the studies that we're obtaining on this patient the majority of the workup can be obtained very, very expeditiously. And then finally, she also has a thumb contracture, and the thumb is in a position that is provides her with minimal function. And once again, just to X-ray is necessary to evaluate the condition of the carpal metacarpal joint. We come back to this boy. This boy has the wrist contracture. X-ray is necessary to look at the wrist and the anatomy. He's a 5-year-old boy, so we know that the wrist is the carpal bones have been growing in an abnormal position to make amends for the position of the wrist. So nothing special there. He has significant absent functional muscle, and for this, an EMG is necessary in planning for possible free functioning muscle transfer as what the possible nerve donor would be. Also, in regards to the absent functional muscle and the free functioning muscle transfer, a CTA is necessary to determine what the vessels are that he has and where whether we could use end-to-end anastomosis on the radial or the ulnar artery, or if an end-to-side will be necessary. Also, with this boy, he has no active range of motion and muscle transfer. It's important to know, does he have tendons that are in the hand, or have these been debrided? And then also, if he has tendons in the hand, are they significantly scarred, and at what level? Are they scarred just at the wrist, or are they scarred in the hand or in the fingers? And will he require tenolysis before the free functioning muscle transfer? Once again, also with the unstable thumb, the x-rays are necessary to look at the joint, this carpal metacarpal joint. But given his pathology, one wouldn't expect that the anatomy of the carpal metacarpal joint would be that abnormal. However, with the instability of the thumb, the physical exam is actually the most important thing that we need here to determine, does he have intact ligaments of the thumb, of the metacarpal phalangeal joint? Are those ligaments intact? Or are they not? And would he be best served with a fusion of his thumb? So the concepts here are very straightforward. This is not conceptually a difficult talk, and the other speakers today will be presenting talks that are much more sophisticated than this, and I look forward to hearing all of them, and I've already enjoyed hearing the two so far. But this is the most important steps to begin with, is you have to start with what the patient needs. Remember, you have to categorize this and place this in a hierarchy. Then you translate the patient needs into the functional anatomy. What functional anatomy is present and what functional anatomy is lost? Then we have to decide what is reasonable for us and what is feasible for us to reconstruct. Of course, we cannot reconstruct everything. So this we then place into a hierarchy as well that best matches with what the patient's hierarchy is. And to determine what is feasible, this is where we obtain the studies to determine the anatomy that is present, the anatomy that is missing, and the anatomy that is dysfunctional versus absent. Thank you very much.
Thank you very much, Dr. Jackie, for a very, very interesting lecture. I may introduce Professor Georgescu, a great friend of mine and a great friend of Egypt. We have him many times in Egypt in our unit, that performing some surgeries and doing some lectures. He's a very, very good lecturer and a very good friend of mine. Please, he will going to talk about the all-in-one reconstruction of the mangled extremity, mangled upper extremity. Dr. Professor Georgescu, please go ahead.
Immediately, thank you very much. I don't know what happened, just a moment.
No problem, take your time.
I cannot find my, just a moment. I cannot see my presentation share, but what to share? Can you see it?
Yes.
Yeah, You see the
Yeah.
presentation?
Yeah.
Okay, thank you.
Just
Sorry for this.
start presentation.
I'm so sorry. So I want to thanks again to all of you to be part of this nice meeting, and to all the others which participate and to look and hear this meeting. I think it's a very important topic to talk about today. So I think the mangled upper extremity, it's one of the most complex upper extremity condition faced in emergency situation. And we talk here about partial or complete amputations or large and complex tissue defects. That's for sure that this kind of lesions will need a very complex approach because, first of all, of the anatomical complexity of the hand itself, and because we have to think about the need to restore the function. First of all, we are talking about hand, and the hand is mandatory to have a good functionality. So the keystone of obtaining such a functional hand is to do an as complete as possible reconstruction, and as soon as possible reconstruction too, and also as soon as possible beginning of the rehabilitation. I think those are the three key points of obtaining a good functional result. So this is possible in my mind just through an orthoplastic and microsurgical approach of this kind of lesions. That's for sure that not long time ago, this kind of lesions like that, it's a very complex trauma through a very complex mechanism, crash, torsion, and elongation, were considered untreatable in the past. But nowadays, through a very, very nice orthoplastic microsurgical approach, we still can obtain this kind of results with a very acceptable residual function. Anyway, it's mandatory nowadays to talk about microsurgery helping this kind of reconstruction. And we assist nowadays to an impressive development of the microsurgical techniques, which are helping very much the surgeons to obtain good results. The main steps in approaching a mangled extremity, and especially a hand mangled extremity, okay, is the assessment of the patient and of the lesion, the debridement, and the reconstruction for sure. Let's talk about each one of them. If we assess, okay, the patient and the lesion, the three main factors concerned to the patient: profile of the patient, and I'm talking here not only about the biological aspect of the patient, but also about the profile from psychological point of view, because it's very important to have a very cooperative patient. If not, what we will do there will be not a successful case. The team experience and the availability of multidisciplinary assistance is also very important. And here I'm talking about an orthopedic surgeon, a plastic surgeon, and also for sure, both of them habilitated more or less in microsurgery. All other aspects are also very important and should be taken into consideration when we are judging to resolve this kind of cases. Anyway, the first question is salvage or amputation? It's a good question because sometimes we have this kind of lesions, but nowadays being experienced microsurgeons, we can try to have at least a tripodal hand, which is essential from functionality of the hand. So in this kind of case, we can replant 2 fingers, as you can see here, and we can cover and resolve the venous drainage of the fingers by using a very nice venous flap to flap harvested from the forearm, the same forearm. So we can have a tripodal hand, which is important from functional point of view. But for sure, in this kind of lesions, it's a neglected electrocution case, which arrived in our department, for example, after 48 hours. You have nothing to do. That's for sure. You have to think about life saving and not to extremity saving in this case. So you have to amputate, but through microsurgical possibilities, you still can solve the problem, okay, by covering this stump to preserve enough length for the stump to receive in the future prosthesis. So by using a thoracodorsal artery perforated flap, you can solve this problem and you have a good stump to be prototyped in the future. Let's talk about debridement now. It's of very high importance especially in the attempt to achieve preservation of lasting function. So you see here, we have this kind of lesion. So first of all, you have to debride very well. The debridement should be enough aggressive, but by paying attention to the preservation possible elements to allow a possible reconstruction after that. You see, we have bone problem, we have tendon problems, nerve problems, and so on. After repairing everything, we have a huge defect, but by finding a very nice perforator from the radial artery here, you can use this skin as a proper perforator flap to cover very nice the defect and to obtain this kind of coverage and functional rehabilitation of the hand. The same is possible also in neglected infected lesions, but in this case, you cannot do the reconstruction in the same time. You have to postpone the reconstruction, sometimes for more than 48 hours, okay, and to do more debridement, okay, to be sure that you will have a clean area to be covered. And in this case, after 72 hours, you can do a very nice coverage by using, for example, an anterolateral type perforated flap. What about reconstruction? And it's very important, the timing of reconstruction. Generally, in the last decades, a lot of surgeons talked about the necessity of an earlier reconstruction, which is better from functional point of view, to obtain a better functional result. So, first of all, was Marco Godina, which in his emblematic paper, okay, advocates that in the first 72 hours it is better to do the reconstruction after the debridement. Ninkovic et al. Did a new classification and introduced this kind of primary free flaps, which means to cover the defects after an interval between 12 and 24 hours. We consider that this is the optimal interval to have a good coverage and functional rehabilitation. But based considering that any kind of lesion can be approached like an amputation, because what is a mangled extremity? It's like an amputation with a lot of skin and other soft tissue destruction, but also about bone problems and so on. So in this kind of amputation, you are obliged, it's mandatory to do the all-in-one reconstruction to obtain a good functional hand. So why not? In those conditions, you see the result after this kind of approach. Why not to do the same in emergency situation? And we introduce a new step in this kind of classification, considering that the immediate emergency free flaps, so like an all-in-one reconstruction, which means to do the reconstruction in the same stage with the debridement. So in our hands, this works very nice, and you see this kind of partial amputation with this kind of recovery after doing a free flap coverage in emergency. So, in conclusion, the better way to obtain good result is to approach this kind of cases like an amputation. Here is a very young boy with this kind of lesion, with missing amputated thumb, with a destruction of the fourth finger, a huge defect here on the forearm, with lesion of the vascular nervous ulnar pedicle. So what to do with this patient? So we did the debridement, and after that you can do a very nice flow-through flap in a piggyback manner by using a contralateral radial flow-through flap, for example, to cover the defect here, and a big toe transfer revascularized through this flap, okay, to reconstruct the missing thumb. And this is the final result, which is a good functionality and recovery of this practically destroyed hand. So, for neglected cases or infected cases, it's possible to do the same, not for sure. In this kind of cases, you have to do the debridement, and after that, maybe you have to do another debridement next day, and only after that, you have to do the final reconstruction. So you see a bad injury, neglected one, infected, so you have to excise, to debride everything, and just after 24 hours, for example, you can cover by using an early emergency flap, like an anterolateral type flap, including also some fascial lateral strips to reconstruct the extended tendons. And you see the result is rewardable. But in this kind of lesion, for sure, you cannot do the same. You cannot postpone just for 24 hours. You have to do more debridements for this kind of lesion because it's a neglected hot calendar trauma in which you have to do more debridement one day, another day, and just after that you can cover the defect. You have to replace the missing tendons here by using a gradually dysfunctional free flap transfer, for example, to obtain this kind of lesion. So it's possible to do this kind of maneuvers also in emergency, but not immediately, just after some intervals, after more debridements. What about reconstruction? This one depends to the type and complexity of the lesion. The reconstruction is generally, because we have generally soft tissue or more complex defects, okay, we have to use local, regional, distant, or free flaps. It's possible to use local flaps in a mangled extremity. Sometimes, yes, if the defect is not too big, like in this case, you can use a very nice bilobe perforated flap based on the perforated dorsal metacarpal arteries, and you see how nice you can reconstruct. The patient is able to start immediately the movement. This is more important. Elegant, because nowadays we rediscover practically in which you can do this kind of excised excision, and after that you just design the keystone and advance, and you have a nice closure. Also, in bigger defects, you can use the same procedure, cover this kind of defect here, elbow. Regional flaps. Generally, it's considered that they are rarely possible in this kind of lesions because of the extent of the location of a supplemented area flaps in this kind of complex injuries. And let's see some examples. For example, here is on the distal part of the forearm, okay, and after repairing everything, replanting, revascularization, okay, you can use a very nice propeller perforated flap based on a perforator proximal 1 centimeter to our suture in the cubital artery, for example, and you have a nice coverage and a very nice functional rehabilitation of the hand. Because the advantage of using a local or regional flap comparing with a free flap is the fact that the patient can start the movement, the kinetotherapy immediately after surgery, because you do not risk thrombosis or spasmus of the repaired arteries or veins. There are some criticism about proper perforated flaps because of the close location of the perforator, but as you can see here in this case, in this damaged area, we can cover with a very nice propeller flap, and the perforator, the origin of the perforator, it's at long distance from the injured area, so you can use very sure this kind of flap, and you have a very nice coverage of the defect. Sometimes it's possible to use this kind of propeller perforated flaps also in more complex injuries, and here you see a degloved hand and forearm, partially degloved forearm. You have this lesion. You have to use something to wrap around the thumb, okay, to cover the defect. You have also a defect here. What to do? So we found here a very nice perforator on the partially degloved skin, coming from the radial artery, and you see how nice you can cover the defect by using this very economical method. And the patient is able to have a good functionality. Of course, we have to deepen in the future the first web space, but anyway, the functionality is very nice. Or in this kind of lesion, it's also a very, very damaged area, and you see how nice we can use this nice flap, proper perforated flap, based on a perforator from the cubital artery here. So what about free flaps? For sure, free flaps represent in this kind of lesion the best option. The indication is depending to the complexity of the lesion and to what about we are expecting to obtain there. So if we have just to do a skin coverage, and in this case, it's a neglected burn injury with this kind of practic circular defect. So by harvesting a very huge, okay, anterolateral type flap. You can wrap around the flap to cover all the regions, both volary and dorsally. Or in this kind of lesion, when you have to respect these thumbs here of the fingers, and you can use a very nice also anterolateral type flap, okay, to cover all this area and to obtain this kind of coverage. And in the future, you have to separe probably the fingers and to put some toe transfers after that to have a more functional tripodal hand. So if you have also to do revascularization, as we can find in a lot of amputation with skin defects or more complex defects. Here it's a skin defect in a replantation, and you can use a very nice flow-through flap from the other forearm to cover the defect, and you obtain a very functional hand. It's an all-in-one reconstruction, like in a replantation, that's normal. If you have also to do a functional reconstruction, because you have also some missing tendons, for example, you can include in your flow-through flap also some vascularized tendon, an all-in-one reconstruction. But sometimes you have more, practically an amputation in the middle, this kind of more than 7 centimeter length, the humeral shaft defect. So in this case, you can use a very composite flap, including the serratus anterior, latissimus dorsi, and a rib segment to reconstruct the bone defect here. The pedicle one, and you see after 80 months, the patient is practically recovering his function after repairing, after replanting a middle arm. So another case similar here with a missing metacarpal, first metacarpal bone, which is necrotized here. And you see by using a rib segment, like here, you can obtain this nice recovery and functional rehabilitation. Sometimes you have also missing fingers. In this case, you have to think about to obtain a tripodal hand. You have 2 fingers which are also damaged. You have to revascularize and repair the tendons here. You have to cover this defect. You have to do a reconstruction of the thumb. So by using a flow-through flap, you can revascularize through it. Toe transfer in emergency is an all-in-one reconstruction, and you obtain a very nice tripodal hand with a very good functional rehabilitation. So, in summary, I think the ultimate goal in the reconstruction of complex injuries of the upper limb is to obtain both a stable coverage and an as complete as possible functional outcome. I'm repeating, we are talking about hand, and the hand is especially important from functional point of view. The radical surgical debridement, the choice of the right moment and method of reconstruction are of paramount importance in obtaining a good functional outcome. And for sure, in my mind, in my hands, I'm considering that the primary all-in-one orthoplastic microsurgical approach, whenever is possible, is the better way to obtain this kind of achievement. Thank you very much again for inviting me and to be part of this amazing webinar. Thanks a lot.
오늘 역시 카메라 웃으세요? 뭐 애까? 내가 가져야 돼요.
So thank you, Professor Joe Gerson. So next we'll have someone from Japan. So we'll have Professor Professor Hiroyuki Gotani from Japan, from Osaka. He is the Chief of Service of Hand and Orthopedic Trauma Microsurgery Center, Osaka Hospital of Japan Sea Affairs and Relief Association. He's also the Vice President of the Japanese Society of Reconstructive Microsurgery. So he's going to talk about the treatment of complex injuries in the hand, combined techniques using microsurgery and external fixator. So without further ado, Professor Gotani, please.
Thank you, Professor Falk, and I'm very grateful for inviting me to this nice symposium. And okay, I start. This is my hospital, and this is technical university. I developed my instrument with a professor there. This is a device for releasing the PIP contracture, modified Lizarov method. This is a bone lengthener, and this is a device for releasing the web contracture. Okay, presentation today. We call these technique as formative hand surgery, microsurgery, reconstruction, and following combined method with tissue lengthening. Presentation divided 3 parts. First one is the first wave plasty, and the second one is the functional recovery for PIP joint using external fixator. Third part is the bone lengthening and transport for reconstruction of missing fingers. The first part, we have applied the Resolve mini fixator for the first wave contracture. The technique introduced here is modified original Resolve technique. Clinical cases shown in slide. 3D expansion of first wave for severe contracture after trauma for moderate cases. Composed of two at 19 degrees. This is a method for severe contracture after trauma. It's for severe cases. Linkage between index and thumb is composed of 2 rods that cross each other at 19 degrees of angle. Okay, we measure the results for radial abduction, index thumb distance, and active radial abduction angle, compared with contralateral side over the 84%. This is a case, complex injury in the hand, plus scapular flap performed at the first operation. This is but unfortunately, contracture happens in CM joint. So after applying the external fixator, this is 2 months after. As a final result, 3 months after, compared with contralateral side, more than 84%. So next case, suffered by the printing machine, it's a medial plantar flap performed. Web plasty by the external fixator and estimated finally as grade 1 by chain score, compared with contralateral side over the 87%. This is by press machine, deprotension of the thumb performed with dorsal skin reconstruction by multiple venous anastomosis. First wave plasty by the usual fixator is also estimated as grade 1 compared with contralateral side 94%. It's a like thumb index crash injury. Index replanted as a thumb base. This indication for polarization. Index moved gradually by the external fixator. This is estimated as grade 2. Please note, it looks like a first wave, but wave. This is a severe bilateral deglobing plantar flap and the first wave contracture release. Finally, he can slow like this. It's his important hobby. And 5 years after, right hand. How to manage the web contracture? There are many methods, but to differentiate of donor vessel or after free flap, using external fixator is a useful method, and we can use it as one selection. Next topic, finger replantation at the PIP joint level. The key for the functional recovery of the replanted finger is successful primary reconstruction, planning of secondary reconstruction, and following rehabilitation. We present management of amputated fingers at the proximal phalanx or PIP and MP joint level using with external fixator. 25 fingers in 13 patients, including clean cut, deglobing, and crash injury. These are details of clinical cases. The first case, the amputation by the ice cutter, we reconstructed FTP and other soft tissue. Venous flap used to avoid the tension of soft tissue above the artery. It's a rehabilitation program. 4 weeks after rehabilitation, Compass PIP was applied to allow joint traction. 4 weeks assist active and 6 weeks passive ROM. Between the exercise in the night, joint was fixated at the angle of -10 to 20 degrees. After 8 weeks, and 6 years from replantation, term was 77 and the Japanese score was 91, excellent. And the next is a modified resolve mini external fixator developed in Japan. We call it as a global hinge fixator. This is a case of cost osteochondral graft after replantation, left index incomplete amputation. X-ray on admission. At first, when we replanted to keep the joint space for following the cost osteochondral graft. Before graft, we applied the fixator and passive ROM like this. And we use computer-assisted cost osteochondral graft method, digital data acquired from CT. Yellow portion means the mirror image of the normal side. According to the 3D data, milling of the bone was automatically done. This is the graft fixated. 19 months from graft, term was 75%. The next case, lightning finger incomplete amputation, the loss of proximal phalanx head. This is the global hinge fixator, a single type. This is the passive movement bar. With the rotation of this nut, the finger will gradually flex. And this is a M3 unit which enables joint space traction. This is the center of rotation. Please note this patient flex with the help of fixator, but it is a before bone graft. This is a photo during operation. This is a graft, automatic milling by computer method. After 5 years, the result by the JSS score was excellent. And now, with the basic research of my university, the rotation center changes like this. So according to this physiological study, we developed a global hinge fixator double type. This is the inner hinge and this is the outer hinge, which works as a guide. Right middle and ring finger incomplete amputation. We apply the new fixator in this case. It's a final result excellent for right thumb complete amputation and the index incomplete amputation. Please note joint space is narrow. Joint traction by the fixator. Please note this is enlarged joint space. 23 months after replantation. This is an incomplete amputation right index reconstructed by the resolve mini fixator. This is on admission at first, so temporary fixation by the fixator and change the structure of the fixator. And he can do the active ROM exercise under PIP joint traction. This is the final result. So external fixator vs simpleton lysis, external fixator group, almost average term is the same, but these group including crush and more local crush injuries. Only application of the external fixator such as CPH and global hinge enable traction of the PIP joint. With the same device, we make it possible to allow both passive and active ROM exercise. This is a simple bone lengthening after replantation of the jigit, and this is a right middle finger incomplete amputation, FDP preserved. Please note, with insertion of the wire prevents the shortening of fingers. Bone transport performed, and finally, before consolidation, gradually, please note this proximal phalanx moves distally. Okay, and finally, we angulated the proximal phalanx. And angulation of the proximal phalanx enables the grip of the finger. A press machine injury covered by abdominal flap. Both bone lengthening and web plasty performed at the same time. Okay, and it's a final result. Okay, next, last case. All fingers were amputated like this. And the great toe transfer performed on admission immediately in this case. Also, dorsal ulnar artery perforator flap used to cover the loss of skin area. Next surgery, we performed peroneal flap. And this is just after the peroneal flap. Okay, and for reconstruct some function, some metacarpal bone lengthening, we selected double metacarpal bone lengthening. We cut here and here, double bone lengthening, 11 days and 33 days, lengthening stopped. And after 104 days, bone consolidation we acquired. It's enough, we thought, but no, 3 fingers, but the patient hoped strongly the other finger for throwing the ball. And the new middle finger was cut and lengthened to make 2 fingers from one. At first, it's a 1 finger, but separated, and bone lengthening. Okay. With application fixator, he can do the rehabilitation. It's a final result. He can throw the ball as he hoped. And now, under rehabilitation, to pinch the small things like this. Discussion. The history of user of mini fixator started with Professor Sawaizu and our group. And the merit of this fixator can be fixed on the dorsum of the finger, flexible and application for many types of reconstruction. This is from injury. Phalanges for healing index over 100 days, but metacarpal bones like average 60 days. So double bone lengthening is effective in some reconstruction as reported. Conclusion, formative hand surgery, our technique centered on soft tissue and bone lengthening with an external fixator is an effective solution to the treatment of various deformities and losses after hand trauma. Thank you very much. Mulțumesc. Grazie mia. Domo arigato.
Welcome. Cu plăcere.
OK。音出たこれ。音が出るようになったね。
Okay. So thank you. Thank you, Professor Kotani. So thank you. So yes, as I said, there will be questions at the end of all the presentations. So without further ado, we'll invite our next speaker, which is Professor Uno Batestein, who is the head of traumatology and head of hand surgery and microsurgery unit in Torino, in Italy. He's also the past president of the Italian Society of Microsurgery, past general secretary of the European Federation of Societies for Microsurgery, as well as the past president of the Italian Society for Surgery of the Hand. So he's going to present to us the reconstruction of the mangled hand. So without further ado, Professor Bruno, please.
Thanks, Margaret, and hello, everybody, and thanks to the chairman for the invitation. So my talk will come after the previous one, showing many things. So I will try to share with you my experience on this topic. So don't forget, you have to treat a patient, not just a piece of the body. As more and more we have amputation or mangled hands and lower limbs in polytrauma patients, as you see here in these 2 reviews. Of course, initial treatment has to be done by a multidisciplinary team, and you have to apply the well-known rules of damage control. So life before limb. But if you know that 80% of these patients polytraumatized can be anyway treated by early total care. We have a 20% of cases that cannot be replanted or reconstructed because of the several general conditions. However, we have in big centers damage control resuscitation. That means and so on, combining this with may preserve limbs that previously would have been amputated for fear of developing exacerbating triad, terrible triad. So this is the reason why to centralize these patients. I show just a case of an aged guy with a severe trauma without head trauma, but just limbs trauma with bilateral crush amputation and also lower leg amputation by G-crane. You see the limbs. We decided to use some parts of the limb, trying to do a kind of on emergency Wilkie procedure, putting and replanting 2 fingers on the directly on the radius, allowing the patient afterwards to keep objects, but overall to smoke, as he preferred to do. Then, of course, you have to classify the lesion through scoring systems, but we agree with the previous speakers that all these systems are able to identify patients requiring amputation or reconstruction, but none of them was able to predict functional outcomes. So that means that in the decision-making, we have to involve white-hair colleagues. We have to share this decision with experience using guidelines and methods of reconstructing. I had the chance to meet this guy, the first one to publish a big segment replantation. And then let's talk and start with the indication for upper limb replantation. Of course, timing, because timing is crucial, especially in a big segment, but patient motivation is important. And as in red light, going from green to red, we see that the segment is important because, as you see, for small segments, thumb is green, while long single digit may be discussed. And you see also that age is important, child always. What about 70 years guys? And of course, traumatic mechanism. Green is guillotine, and avulsion injuries perhaps are not so good indications. So of course, we have to understand our problems through experiences and case series. So this is a published series on injury, our series of about 60 replantation of thumb. And you see a high survival rate. Of course, this is a perfect case with perfect reconstruction of the function. But what to do in this thumb is to be amputated? No, thumb is always to be salvaged. Then you can revascularize, use local flaps, and you see that the patient can back to normal hand activity. So also for big segments, looking at our series of 52 replantation in this period of time, 10 years period, that was published on JPRS and also on Springer, you see that unfortunately we have to face more and more with crush and avulsion injuries. You see that a number of these lesions in mangled amputation is increasing over the years. So this is an easy case. Of course, you will have a perfect functional result. But is this a case to be replanted? This is a left hand in not such a young patient, but we think yes, because it's a complete hand. And so the long fingers are revascularized after a flap, and afterwards thumb replantation. And you see that we shorten through a joint fusion radius with the metacarpals. And you see that at the end, we have a sensible and gripping hand. And the survival rate, if you do a correct surgery, is good because we have about 100% of survival rate. But if we look at the functional results according to Chen, you see that anyway, even in big segments, you may have 61% of very good result. But if we divide the very distal, so forearm and hand, you will increase to 75%. And of course, if you go proximal, this rate will decrease. But anyway, you have something better than a prosthesis. Of course, doing this kind of surgery, you may have complications. And if you look at leg complication, you may have non-union, bone infections, also brachial plexus palsy, needing secondary procedures, going 44% of tendon transfers and on and on. Then how improving reconstruction possibilities in mangled hands? Well, thinking, because this is a kind of art, because we have to follow also the bank finger, bank tissue concept. So from single non-viable to the entire viable tissue. As in this case, everybody knows the possibility to replant a finger as an index finger in place of the thumb. And you see this immediately after the operation. And the final result with a perfect function in this aged patient. And going to the spare parts concept, that means tissues of amputated or unsalvageable limbs that may be used for reconstruction of complex defects. For example, in this case, this is not to be replanted. If you have to amputate this patient, it will be at the arm level, but this completely makes the difference if you preserve the elbow. So why not using the flap of the distal segment as a free venous flap, covering the distal thumb, allowing to wear a prosthesis afterwards. Then timing is crucial because we can do, as Dr. Jesco showed, the emergency early reconstructions. And of course, you have absolute indications that mean exposed vital structures, high risk of infection. You may do your revascularization using flow-through flaps, or you may use salvage flaps. And also relative indication, why not using a finger talking with the patient for a definitive aesthetic reconstruction. But after the injury, you get with this loss of tissue, we had revascularization through a vein graft, and then on emergency, a gracilis flap is used, covering the vital structures, that means vessels, but also the nerve reconstruction. And you see here the patient some months afterwards also getting back to a thinner muscle motion. And looking at finger, flow through flaps. This is to be revascularized with a venous flap, giving revascularization, covering the digit, allowing secondary tendon reconstruction with this perfect, complete functional reconstruction of the finger. And of course, we have complications, we have problems, we are able to do secondary reconstructions, as in this case of proximal avulsion by motorcycle accident. In Italy, everybody thinks to be Valentino Rossi. Of course, the distal segment is, where you see the necrosis of this leg. It's very easy to cover it. Latissimus dorsi, also the biceps reconstruction, as you see here. And what to do in this kind of patient? Maybe we think it's not. We take a block of the pulp of the thumb, the reconstruction 6 months afterwards with perfect pinch and 4 fingers.
So we have Professor Lucien Giger from Germany. He is the chair of the Department of Plastic and Reconstructive and Hand Surgery and in Oldenburg, Germany. And he specialized in reconstructive microsurgery. And he's going to give us a talk on the microsurgical reconstruction of the mangled lower extremity. So, Professor Giger.
Hi, thanks everybody. Can everybody hear me?
Yeah. Yes.
Okay.
Yeah.
Thanks everybody for the invitation. It's a great honor to be here today. I especially want to thank my good friends Dr. Jesco and Uno Batestein for as part of the EFSM for inviting me here. Is again great to talk in front of the CCOT faculty. Could you please, Bruno, can you please go out from your share screen, because I cannot open my talk? Okay, so can everybody see the slides?
Yes, sure.
Okay. So I was asked to talk today about the role actually of the microsurgery in the reconstruction of the mangled lower extremity. And this, I would like to start by telling you that I would rather concentrate on my talk on the role of microsurgery in actually salvaging these severely injured lower extremities than rather talk about other issues regarding this very, very, very complex disease. So, of course, everybody knows the publication of Johansson, 1990. They were actually the ones that established and brought to the world actually the extremity score. And this is, of course, their initial conclusion that a score value of over 7 predicted amputation over 100 accuracy. After the years, further along the way, as you already heard from my previous co-speakers, there are several scales that have been developed in an effort to try to have a kind of a mathematically proven evaluation of a severely injured extremity that could be either prone to be better amputated or better reconstructed. So in 2008, this is also an instrumental paper talking with us about this type of lower mangled extremity, where a group of people from North Carolina have taken 493 limbs from a bigger study that took place to evaluate vascular lesions in a lower extremity injury, and they just sieved down all these 493 limbs through 5 different very good established scores to evaluate the mangled extremity. And in the end, their conclusion was that neither of these scores was actually able as sole criterion to provide a good evaluation and an indication for amputation or reconstruction. And thus, all of these scores are actually, they are not unuseful, but they have a very, very limited role in deciding on whether to amputate and or to reconstruct. And another paper, 2017, wrote by another group of people from the United States. They have did a meta-analysis on several papers that were published during the last 20 years regarding scores to evaluate the mangled lower extremity. And what they found out was actually that mangled extremity score of lower than 5 or equal to 5 was rather predictive for a reconstruction than an amputation. So in the end, what they conclude is that, of course, these type of scores have a high sensitivity, but a very, very low specificity. So again, a thing which has been said today several times, and it's I think it's an opinion that we all share, is that those scores cannot be used as a sole criterion for evaluating this type of surgery, this type of lesions. I'm talking mainly about reconstruction and role of microsurgery, but I think when talking about mangled lower extremity, it's also very important to talk about the evolution of the prosthetic limbs and the prosthesis during the last 10 to 15 years. Nowadays, we have bionic prosthesis enabling amputated patients actually to not only to have a normal life, but to be to run competitive sport. And this is one of my actual countrymen that has been becoming very famous during the last 5 years in the Paralympics. So these prostheses are offering nowadays a very good option when reconstruction is not anymore a choice. Also, Professor Scott Levin, the sole pope of the orthoplastic surgical approach, because we have to mention that Professor Levin was the first one that defined this type of multidisciplinary approach of both orthopedics and plastic surgeons to try to salvage extremities, is saying in one of his last papers, 2011, on the roles of plastic and orthopedic surgery in limb salvage, that when myoelectric prosthesis will be able to outperform limb salvage, we will all face a profound paradigm shift. And I think this is very true, and it's coming to us. So without further ado, I would like to talk about the principles of treatment, and I would like to present you some cases, the way we approach mangled extremity, and in the end have some closing remarks, focusing on the lower extremity salvage. So what are the principles of treatment in a lower extremity, Of course, you need the fastest OR slot. You have to radically debride. These are things that have been already mentioned by my four speakers. You have to stabilize the skeleton. Of course, you have to vascular injury. You have to revascularize as quick as possible. You have to evaluate the soft tissues. Of course, those extremities are prone to compartment syndrome and further loss of soft tissues and functions through the loss of the ischemic muscle. Of course, when dealing with such massive trauma, we have to inspect the partly amputated or completely amputated body parts and think about spare parts and use those to harvest soft tissue that will allow us to maybe close a good functional stump and not try to replant something which is not replantable. Of course, you have to think about early soft tissue and bone reconstruction, because it's not always that you can reconstruct the soft tissues and bone in the first session because of unstable patients. And what Professor Batestein mentioned about life for legs, so life comes first. And of course, in the end, as very important is when dealing with lower extremity to prevent equinus contracture, which can be very, very debilitating. So regarding soft tissue reconstruction in the lower extremity, we have the evidence with the latest paper published by Geoff Hallock in Journal of Reconstructive Surgery 2018, showing us here the evolution of flap priorities during the last 50, 60 years, where you can all see that in the lower extremity, especially distal lower leg and foot, we are mainly talking about free flaps all of the time. Why? Because of course, at this level, one does not have many other, not many other options in terms of local flap coverage. But talking about mangled extremities, we have mostly to deal with this type of defects. So we are talking about massive avulsion injuries. We are talking about massive bone defects, fully exposed functional structures like tendon, bone, vessels, joints, and so on. So in this case, there is not very often the case that we are going to be able to use a local solution to achieve an adequate soft tissue coverage. So of course, our approach is also, especially talking about the shank, distal lower leg, and the foot, to primarily think of the free flap, and of course, talk about perforator, local perforator flaps, in a second instance and never first choice. I give you here an example. This to the left, you have a 60-year-old lady which suffered actually an open luxation of the tibial-talar joint with injury of the tibial posterior artery, with exposed bone, exposed hardware, with a MES score of 6, with two criterions being applied to her. So this is one type of wound. On the other side, you have a massive crush injury after a motor vehicle accident. Of course, here we always plan to cover this with a free flap, but sometimes you have a very good, very nice perforator, and you can use this to cover the wound using the local solution. But again, we are talking about a limited wound. We're talking about open joint and free exposed hardware. But in case this solution was best for this patient. Now, of course, talking about this motorcycle accident where we have severely contaminated wound with grass, and stones and massive contamination of bone, soft tissue structures, it's mainly not possible to reconstruct the soft tissue in the first session. So you have to wait to obtain a clean swab situation. And thereafter, of course, you need a free tissue transfer. Like in this patient, we used a combined serratus anterior latissimus dorsi flap. This guy suffered further on a bone lengthening to Elizarov, so to be able to reconstruct his tibia, and now he's be able to again drive his motorcycle. So regarding soft tissue reconstruction in this type of injuries, what we apply in our department is are the following the following 8 rules. So first, you have to have the clean wound. If you can obtain a clean wound in the first place, then just wait debride, like my co-speakers have already pointed out, and do the reconstruction further on later. Evaluate the remaining soft tissue envelope. Functional status and ideal prognosis of patients are very, very important in together bound with patient age, the familiarity and assistant compliance. Of course, at this point, you have to decide, okay, is this patient better suited for reconstruction, or we should proceed with amputation as prosthesis. Further on, if you decide to reconstruct, you have to see, of course, the soft tissue needs according to the region functional outcome. Do you need concomitant bone reconstruction or definitive fixation? Vascular anatomy chose the ideal as well as the most ideal flap. By this, I mean to always have a plan B in your head when you go with such a patient operating room. And of course, you need to achieve a fast coverage of the lesion. So here's the first case, female, 22 years old. It was a Gustilo 3B fracture, motorbike accident. You see to the left of your screen the initial x-rays with a pretty comminuted fracture in the middle third of the shank. I don't know if you can see it, but in the first angio picture, you can see a flaring off of the tibial posterior artery directing the zone of injury, indicating a bad posterior, probably an injured, partly injured tibial posterior artery, but with a good tibial anterior peroneal artery and a good plantar arch. So, of course, after initial stabilization with an external fixation, our orthopeds have the definitive bone fixation. And of course, what is marked with blue, it's actually the entire space that we have subcutaneously, which is free because this was a rather avulsed injury. And of course, the exposed bone. Our orthopeds usually use for this type of small bone fragments in the big bones, shaft fragments, they use fixation and they use a bone morphogenic protein, a recombinant human bone morphogenic protein to try to stimulate bone healing. And we came, of course, at the end of the surgery and did our soft tissue coverage with an anterolateral thigh flap. In the end, the patient needed, in a distal part of the leg, a derotation osteotomy to achieve a good access of the leg, and you have the final result. Actually, this is almost a year after the last surgery, the patient being completely actually rehabilitated. So I've moved further on. The next male, 56 years old, Gustilo 3B. This was a severe crush injury. You see how the wound situation when we got the patient, massive compartment syndrome, that after debridement, of course, we had the problem that so we did within we did graft fixated and achieving not a very good, about 4 months after surgery. He was still being afraid to fully mobilize his foot, but he was very happy because he was able to hold on his foot and live further on with this situation. So this is the next case. The next case. This is actually an old case, so the patient is not presented to us in acute phase, a Gustila tri-E, a distal part of the shank, open fracture, dead bone. You can see this fragment of the tibia there that had to be excised. And in the first stage here, we did a good soft tissue coverage with the latissimus dorsi muscle, and after which our orthopedics department installed a bone destruction system. And you can see to the right of your screen the amount of bone destruction and the landing of the remaining tibia shaft direction the tibiotalar, the reconstruction of the bone. The next I want to present to you is a case where we have also a type of vascular involvement. Is a 76-year-old female with the Gustilo tri-B fracture actual luxation, anterior luxation of the knee joint. From the CT, you see a continuous popliteal artery. However, the popliteal artery was partially thrombosed and needed to be revascularized, and in the end developed a huge compartment syndrome with a huge hematoma into this area that had to be debrided, and this is the soft tissue defect remaining. Of course, when we have this type of situations, we need soft tissue coverage. We don't have a local solution for these patients, so we will need the free flap. So the big problem in our department, we don't like to go distal to a reconstructed artery to search for a recipient vein, that the popliteal artery and vein. To have, you can see here, this is actually a very expedited procedure, and you can very quickly have recipient vessels of very, very good quality. So this is the lat dorsi muscle that we hooked up on this vein graft, and this is the final results after covering the defect. And the next patient is Gustila tri-C, 51 years old, high impact trauma, car accident, massive destruction of the proximal tibia and the knee joint with a severe soft tissue avulsion injury. You can see here the 3D reconstruction of the preoperative CT with the amount of bone destruction. And to the right, you see a complete stop in the popliteal artery. So it was an ischemic limb that needed to be reconstructed. Initially, the veins the artery was reconstructed, compartment decompression, external fixation. You can see the skin partly going direction necrosis. The vascular surgeons were consulted again whether the vascular reconstruction was good, what they did, because the patient compliant in the same time of a pretty big pain syndrome in the shank. The bypass was needed to be revised. So in the end, they replaced the entire P2 portion of the popliteal artery with a piece of Gore-Tex, vascular prosthesis, orthopeds, achieved actually under these circumstances. Of course, reconstructing the articular surface of the tibia into the knee joint is in these circumstances very, very difficult. And this is what we got in the end. So after debridement, you have exposed bone, hardware, missing skin, and of course, in this situation, you can only reconstruct this using free tissue transfer, which we did in the same way as the previous case by doing a VAS. Of course, in the same time, avoiding the reconstructive popliteal artery and deeply scarred and very swollen tissues of the shank. So after doing the vein, we hooked up a serratus anterior flap to the graft, and you see here the immediate post-operative result as well as the result 2 months after surgery. This is a pretty actual case we did a couple of months ago. So he's still doing his rehab, but he's feeling well, and this is the last picture I have from him. So it's pretty cool. Male, 61 years old, Gustilo tri-B, massive cross injury also. North in Lower Saxony, where I'm coming from, they have these big tractors working the fields. So somehow he managed to got his foot clamped into this very complicated wheel system, and this is what results in bilateral injury. You have on the right the completely missing skin envelope with a pretty severe ankle fracture. On the left, you have a exposed ankle joint with a skin defect. So this is the bone situation on the right. You can see the bone injury. And of course, this is what we had in the end after debridement and after stabilizing the patient, which could not be operating from us from the beginning. So completely exposed Achilles tendon. You have the heel that's exposed. You have metal that's exposed. In the same way, we did here also compound latissimus dorsatus anterior muscle to cover the Achilles tendon and cover the exposed part of the calcaneus. And this is the early result. So everything was healing very well, and everybody was very happy. But this is how we got to. So the patient left us from his first trauma, very happy about his 2 legs being saved. But after about 1.5 years after surgery, you see this progressive lymphedema on the right foot. The left was really okay. With a medial superior artery perforator flap that was healing very well there, but the right foot was very bad. Patient had pains all the time, and on top he developed a chronic osteomyelitis into his talus. So in the end, after talking with the patient, we decided it would be better to amputate patients. This is the picture patient sent me when buying his first car that was specially suited for him to be able to drive the prosthesis. So. Looking back to the future regarding the mangled lower extremity, I can tell you that free tissue transfers are instrumental as limb salvage procedures. Amputation versus reconstruction, this remains and will remain actually for the future a multidisciplinary team decision. The mangled extremity scores can help us in take this decision, but should never be used as sole instruments. In front of massive tissue loss like major crust explosion injury, one should really consider amputation or functional reconstruction of the stump and prosthesis fitting. Good microsurgeons are always hard to find, and of course, in dealing with mangled lower extremity, having a good microsurgeon on your side is, as we have seen also today in all the talks, can be a real good advantage. However, microsurgeons are also mortars, and thus we are also prone to failure. Thank you very much.
So thank you. Thank you. Yeah. So maybe Professor Ju, do you want to ask the floor whether there's any questions in the audience, or should we start the ball rolling?
Faculties, there are already several questions have posed. So, and anyone from the audience inside, 有没有什么问题大家 ？Okay. Or maybe we can keep going to discuss. I think there are several questions from the faculties.
Yeah.
Mm-hmm.
So, okay. So I think Professor Kasani was asking the faculty whether any about indication of doing muscular techniques, because a lot of times nowadays, instead of doing vascularized fibular graft, muscular techniques actually works in quite a lot of cases. And actually, even in Hong Kong, we don't do that many cases of vascularized fibular graft. So what do the other faculties are doing? Will you still prefer vascularized fibular graft rather than muscular techniques, or what's the preference?
If I can answer,
yes.
I think that there is a big difference, not in the length of the defect, because of course we discuss a lot on this, but on the site of the defect. Mm-hmm. Because lower limb muscular technique is easier, leading to less complications than free vascularized bone graft. While in upper limb, I think that anatomical reconstruction could be done for functional restoration with the free vascularized bone graft. So it depends, of course, also on the length of the defect, but consider the site.
Okay.
Yeah, I agree with Bruno. I think the better way to solve the bone problems in the upper limb is to use free flaps, free vascularized flaps, or pedicle vascularized flaps, because sometimes it's possible for the humeral shaft, especially because you can use the rib, for example, together with the muscle flap. But also as a free flap, you can use very nice. For the lower limb, I think it's working, but I'm a plastic surgeon. Generally, I'm preferring to use not muscular technique, but to use free flap.
Yes. How about in Japan? Professor Gattani?
Yeah, almost the same opinion, but combined with severe bone defect and soft tissue defect to prevent the infection. So the early reconstruction with the vascularized bone graft is better in the emergency reconstruction, I think. But secondary non-union, sometimes we defect less than 5 centimeters in Japan. Now muscular is indicated like that.
Okay.
So, okay, I think Bruno had a question for all of us about the emergency, the timing of reconstruction. And I think as I presented already, I think that for the upper limb, it's very important to do as soon as possible reconstruction. So I prefer to do whenever it's possible all-in-one reconstruction. For the lower leg, it's something different because there you can postpone a little bit. If you have not precious elements, anatomical elements to cover, you can postpone a little bit more the coverage. So you can have not immediately reconstruction. But for upper limb, I think it's different, totally different. But what is more important, I think, in talking about this kind of reconstruction, it's and especially for upper limb, is the psychological aspect of the problem. Because if you have not a very cooperative patient, you will have not good results. So you have to take your final decision to repair or not to repair, to amputate or to salvage an extremity, an upper extremity, just when you are sure, very sure that the patient will be a very cooperative person. Because if not, you'll do a replantation, you'll do a huge reconstruction, and you'll have any kind of functional result. So this is my point of view regarding this. And the expectation of the patient, because Dr. Hagbord was talking about this kind of needs, what exactly the patient needs, what exactly the patient are expecting, for sure is very important. But when we are talking about the expectation of the patient, we have to talk also about his psychological impact. This is my...
I agree with Dan Georgescu for emergency reconstructions, but my question is also on delayed reconstruction. As in our published experience and according to the orthoplastic approach, generally we have a window of opportunity between 2 to 7 days, because literature says that the number of complications increases if you do late reconstructions, I mean infections and so on. So this is also a problem of organization. So I would like to have a comment about the possibilities in your countries of having a correct timing for these patients. I mean, to do free flaps or flaps in a correct timing.
Yeah, me personally, I did a study and I published this in a paper a long time ago. So about this, and we did some harvesting of secretion and antibiograms and so on, and it was huge microbial contamination after 48 hours. Indifferent of the conditions in which you are keeping the patient, he is safe generally, but generally in my service was possible. Okay, to do this kind of reconstruction, immediate reconstruction, and we start of course the emergency procedure immediately after the trauma, whenever it's possible. This is my opinion.
If I may also intervene here, I think in our hospital we have, as I landed here in Germany several years ago, the orthopedic department was prone to actually take care of the soft tissues by themselves. So I also have to say that in Germany, because we have a very tight-rated work system, the amount of mangled extremities we get, in spite of the fact that we are a major trauma center in the region, is pretty low. So, of course, this was not good. And I saw patients after major trauma with exposed hardware and functional structures 2-3 weeks after the initial presentation. So, of course, during the last years, we actually managed to develop a multidisciplinary protocol where we actually take part into the first surgery. So in the first surgery, we are called to evaluate if we think we can do a reconstruction primarily, we will do it. So we go to the orthopedics department with our team, and they book the emergency reconstructive team, the micro team, and we will do it. And if the reconstruction is not possible directly, then the plastic department, so the microsurgeon will decide when the reconstruction will take place, and I have the possibility to do this surgery any time of day and night.
Yeah.
Most microsurgeons come from the orthopedics, so we have a team to just like perform immediate reconstruction. So it might be different from such as the United States or the Europe, and they have a vascular team or the prosthetic team to work with the orthopedics. But actually, in China, most center they have also microsurgeon in their department, so they can perform the immediate reconstruction. And my opinion is preferred to early repair, and the timing either is less than 1 week. And I have a question to all faculties about the debridement, because nearly every faculty emphasizes that debridement need to be a radically debridement, but how to perform the radically and other criteria for radical debridement. It may be
mid-person, yeah. We cannot hear you.
Can you hear me?
Oh, yeah.
Okay, I'm sorry. So about the debridement, is that need to the senior surgeon to perform the radical debridement, that's like the tumor resection. However, in the emergency case, and I would like to know what's the scenario in your hospital and who will perform the debridement in the emergency case, and how to is quality control.
Yeah, generally I'm doing like that, so I'm preferring to do an oncological excision debridement because you know, by using different type of complex flaps, you can solve defects of the flexor muscle, for example, or extensor muscles, or bone defect. At the same time, by using bone flat, by using I see is much better to do like you are able to obtain, especially for upper limb, to obtain much more good functional results than by postponing the procedure and to have more debridement.
Professor Tu, I can tell you that we use a 3-step procedure in which first we use methylene blue and we take away all the tissue that is just color. Second step, we get back again and we cut everything up to the bleeding of the tissues. And third step, we use 5 to 10 liters of washing. So wash a lot. And we decide which kind of flap.
department, in my hospital, it was very easy to deal with, or to. In the beginning, they of course they want as soft tissue as possible around the bone that was started. I was doing the opposite. I was exposing their bone. So they were not happy about this. But after actually we did the first cases together, and they actually saw the potential of reconstructive microsurgery. Nowadays, after they evaluate the patient and we talk about the operation on the bone, they let us debride the situs. We are doing something similar with what Bruno just said, but instead of metal and blue, we are using a combination which we call volcano. Saline in 1/3, 1/3, 1/3 proportion. The water peroxide is very good to take care of all the massive anaerobic contamination of the wound. It offers you a pretty dead tissues that you need to debride. And of course, when we are dealing with massive lacerations and crush injuries, there are at least 1 to 2 take backs into the surgery and the second day after the trauma to debride again. And usually the free tissue takes place within 4 to 5 days after trauma when we cannot do it directly.
Mm-hmm.
We are all time.
Yeah. For extremity, radical debridement and free flap within 72 hours. It's our method. It's a moderate debridement. The muscle volume is not so much, and we can control the infection if we wait more than lower extremity.
Okay, thank you. And Margaret, I think I already went over time for this webinar. So I would like to close this webinar and thank you all the faculties and thank you for your time and excellent presentation. And also there's so many audience from the Dr. Coutinho's team. Okay, thank you for your show. We have a picture.
Thank you.
We say
Bye-bye.
Take a picture in the
what's that?
All right.
Thank you very much, everyone, and hope to see you again soon.
Yeah.
All right.
Bye-bye.
Bye-bye. And thank you. Have a good
Bye.
weekend.